Yeah, probably we've pretty much covered that. I think the interesting thing about relapsing disease is it tends to be that when you first diagnose it, you have a lot more relapses than you do as the disease goes by. And we're not really sure why that is, but often in immune-mediated disease, it tends to be an upfront immune activation that then results in a sort of, it tends to dampen down. This slide is really helpful in terms of getting your head around what the difference between MS disease that's inflammatory and MS disease that's progressive. You may not be, yeah, so as at the beginning you get inflammation, and that's the immune system, and in the background you can see the blue line, which is the volume of brain tissue, and the subtle blue, I don't know if you can see the subtle blue in the background, which is the loss of axons. So as time goes by, you get more loss of tissue and less inflammation. And that's the difference between inflammation as relapses and the loss of tissue and axonal loss is the degenerative part of the disease. And that's why the treatments are just so different, because there's two completely different pathologies happening at the same time. So the what is my EDSS score is another really tricky one in terms of why is it that doctors know what your EDSS score is and you don't. Often that may well be just because once you leave the room, we do the paperwork afterwards, and it does end up taking a bit of time to kind of calculate things out. So it may not be that your doctor's not wanting you to know what your score is, but it may just be a sort of a side effect of the fact that the paperwork's done after you've left. The EDSS score is a 10-point score, and at the lowest end, the 0 point, is when patients have no symptoms, and when the neurologist examines them, they don't have any signs. So we don't find brisk reflexes or an upgoing plantar. The neurological examination is completely normal. And then as you go further up the scale, there's a higher degree of disability and a higher degree of neurological signs found when the neurologist examines the patient. It's not a linear scale, so I think that the other reason why the EDSS score is sort of along the lines of progression and the discussion around have you got progressive disease or not, what's my score. I think sometimes if your score is high or higher, it does have sort of implications for what the patient thinks the doctor's saying to them. And so I think it needs to be sort of discussed in a way that you understand what it means. But the score, unfortunately, is not at all linear. And so you might feel like if you went from a 1 to a 2.5, that was not a very big climb, and going from a 4 to a 7 was it's not really saying it very well, but it doesn't work in a linear fashion. So you can stay on one level for a very long time and still be getting physically worse. But yeah, so it's not linear. It's helpful in terms of the current treatment. So we're going to talk about the sort of cutoffs for the new treatments, and that's around the 4.5 level, but we'll come to that a bit later on. In terms of the new treatments, so as of November last year, we got access to a lot more therapies. So at the moment we have Copaxone and beta interferon, which have been around for a long time, and then now we've got superimposed on those Tysabri, which is natalizumab, and fingolimod, which is Gilenya. So the Copaxone and beta interferon, ideally the government wants us to not use those treatments so much, and the reason for that is in terms of cost benefit. So those drugs have been around since the 1990s, so we know a lot about the safety profile of those medicines, and they are very safe. They're annoying for patients in that you guys have to inject them, and sometimes that's every day, sometimes that's every second day, and sometimes that's every week. But it's a lot of needles and side effects from the injections. But mostly those medicines are tolerated well, and they don't have a lot of worrying serious side effects compared to the other drugs. The downside to them, apart from the injection, is that they're not that effective. So on average, they reduce your risk of having a relapse by about 30%. And the disability data, so how much they will impact long-term on how much disability you have, and the score on the EDSS score, is very unclear, but they're not thought to have a very big advantage in terms of disability. So where would we use these now? So the Copaxone and the beta interferons, we would use them reasonably rarely as a new treatment. So Copaxone is reasonably safe in pregnancy. So for a young woman who was going to have a family, we might say Copaxone is quite a good drug. You could have that and stay on that when you become pregnant. Beta interferon is probably less well tolerated, and I think we'd use that fairly infrequently in newly diagnosed patients. But in patients who have been on those drugs for many years and who are well, who've been well on those treatments, as long as they're happy to keep going with the injections and the injections aren't causing them problems, if you've found a drug that is effective for you and doesn't have a lot of side effects, then the best thing is just to stay on it. Because as you'll hear, the other drugs bring with them quite a few potential problems. So even though we wouldn't necessarily start people on those medications, if you have been on them and been well, then you're probably best to stay on them. So coming to natalizumab or Tysabri, so this drug is given as an infusion. So it's a once a month infusion, and the infusion goes over about an hour, and then you stay in hospital for about an hour afterwards, especially at the beginning. The main issue with it at the moment in terms of access is getting physically into the hospital can be a problem, and it means you have to come into the hospital environment once a month, which most of you would probably rather stay well clear of the place. So it's kind of that hospitalised environment with the natalizumab that's a problem. The good thing about Tysabri is it's really effective. So whether that's because people have to come into hospital and have to have their drug, we don't know, but it works really well. So most patients who are on that medicine won't have a relapse event, which is, you can imagine how life-transforming that is for people. And most people who are on the infusion, they feel very well. So people would say to me, it's like I come in and I get lolly water. It doesn't make me feel unwell. I feel great on it. So it's tolerated very well. The main side effect from it is that it does have the potential to cause a problem with a virus getting into the brain. And the reason for that is because it works to prevent multiple sclerosis by blocking the immune system getting into the brain. So it stops the white blood cell from crossing the blood-brain barrier and getting into the brain. And by doing that, it stops the inflammation, it stops disease activity, it stops relapses on MRI and relapses in physical relapses as well. So because it blocks the immune system getting into the brain, sometimes a virus can cause a brain disease, and normally it would be mopped up by your immune system, but if you're on this drug, the virus can cause a big problem in the brain. Risk of getting that? Well, by some great genius plan, there's a group of scientists in Denmark who managed to formulate a test, and that's called your JCV antibody. So they've got a test that they then looked at quantifying your risk. So about 50% of us will have the antibody to the JC virus, and that means that if you don't have the antibody to the virus, then it's very unlikely that you will go on to get the virus invading the brain. In saying that, you could still, it would be a very low risk, but if you had no virus detectable in your body, there's still a risk of less than 1 in 10,000, and that's because the lab may have got it wrong, which would happen very rarely, or every year there's the potential that you could convert to being positive. So if you're negative, if you don't have the JCV virus, after about a year, it's about a 2 to 3% chance that you may become positive. It's still very low, but if you become positive, then you fall into the risk category of someone who's positive. So if you have multiple sclerosis, if you're having relapse events, and if you are considering the new drugs, one of the most important questions for your neurologist: am I JCV negative or am I JCV positive? If you're JCV negative, then it's a very good position to be in that Tysabri is a good option for you, and the tablet is a good option for you as well. So there's lots of options. If you are positive, which about 50% of the population will be, so it's a bit of a coin toss, unfortunately, whether you're going to be positive or negative. If that test done in Denmark comes back showing that you are positive, then probably you're better to go on the tablet, the fingolimod, which I'll talk about in a second. But there are some circumstances, especially in New Zealand, where we have stopping criteria. Because Tysabri is so effective, if you're getting close to stopping criteria, even if you're positive, your doctor may say, actually, probably Tysabri is better for you. Or if you've got relapsing disease, so you've got disease activity from an immune point of view, and you've got a bit of creeping progression, sometimes in that situation, even if you're positive, your doctor might say, I'm nervous about how your disease is going. I'm worried that you might meet stopping criteria. And even though it's more risky, I think for you, the Tysabri is the better drug. And that's just because it's highly effective. There are trials looking to see whether Tysabri works in disease progression, but we don't have the answers yet. Feels weird not having questions. You're not allowed to ask me. Therese will kick me off the stage. I'm so used to people talking to me, but I'll keep talking to you. So the fingolimod, again, is a really good medicine. It's effective and it's a tablet. So it means that you only have to come and tolerate your neurologist once you've been established on it, probably once a year, and you'll mostly feel well. There are some patients who don't feel great on this drug, so it can give them sort of headaches, a little bit of a stomach upset, a bit flu-y kind of feelings. So there are some people who do have side effects from this drug, but most people feel well, and in Australia it's the most prescribed medication. People can travel the world, they just take a tablet, they don't have to find a hospital to get an infusion in once a month. So it's a very convenient medication, and I imagine that if from a wellness point of view, taking a tablet once a day, people will feel more well than going to the hospital once a month.